Hello, everyone. My name is Rochelle Beard. I am an infection preventionist. I'm working as a infection prevention and quality improvement consultant in the Louisville, Kentucky area, and I am starting a new series that I'd like to call Let's Talk About It. So want to just talk about different infection prevention topics that, might be a little mundane or boring sometimes if you're just presenting and walking through the facts, but really talk to other IPs and talk about their experiences and really just have more conversations about these infection prevention topics. So we don't have to listen to anyone just drone on and on and on about the same old stuff. So today's topic is going to be about outbreak investigation. And I have invited my friend and fellow IP, Nikki Shore-Maxon, to talk about her experience with outbreak investigation. So Nikki, would you be able to say hi to everyone and take a few minutes just to introduce yourself and your experience and what you do in infection prevention?
Yes, absolutely. Thanks for having me on, Rochelle. I'm excited to sit and talk it out.
Thanks. Glad you're here.
Yeah. So again, I'm Nikki Shore-Maxon. I am a manager of quality and patient safety at a long-term acute care facility in Lexington. And I thought I would just walk you through a long journey that I had with Candida auris. And I will start by assuming that everybody knows about Candida auris, especially since it had its 15 minutes of fame in the news a few years ago. But a little bit about my hospital. We are a long-term acute care facility, average stay of around 25 days. We're housed within a host facility. And that length of stay of 25 days creates a really unique barrier to getting rid of stuff, especially when it comes to things like Candida auris. And we contract with a lot of services that the host hospital uses, including the OR, which really contributed to some of the communication issues that you're going to see coming up. So it was in June of 2022. It was about an hour before I was scheduled to board a plane for the beach. And I got a call from the infection preventionist at the host facility telling me that a patient of ours had tested positive for Candida auris. Now, my chief nurse was in Italy, and the IP that day was fishing. So she was in the middle of a boat when she got the call and then called me. So it was close to 4:30 on a Friday. This is all the cliche stuff that happens. It was close to 4:30 on a Friday. Everybody was going on vacation. Oh wait, it wasn't a Friday. Back off. It was as close to it's a 4:30 on a Friday as you could get for an emergency. And do what?
I said, of course.
Yes. Oh, absolutely. They always say that's going to happen. But yeah, it was everybody getting ready to go on vacation. But when she told me who the patient was, I was really alarmed. He had been, like I said, this was early June. He'd been with us since March. He was admitted from another hospital in the northern region of the state. He had some respiratory issues, hip ulceration, and he'd gone down to the OR in April, and a swab was sent to the lab. Unfortunately, there was a delay in reporting results, so our interventions were all delayed. Now, I mentioned earlier that we contract with the host facility's surgical services. So when he left our facility to get debrided, he became a patient at that host facility for a short period of time. So his records made it look like a quick outpatient surgery. This is all the Swiss cheese holes falling through. Mm-hmm. So before I go on, here's a quick overview of what happened with the swab. So it was sent out for further testing. It made its way to Quest and then the state lab and then our area's reference lab, which is in Wisconsin. We're in Kentucky. They identified it as Candida auris and then they alerted the state health department. No communication that any of this was happening. So we didn't have the patient in any sort of isolation precautions. There was no known indication to do so. So I get my call. I realize the patient's been in our hospital for 6 weeks without any sort of isolation. You have to go into immediate intervention and immediate panic mode, right? So I had to call, like I said, our CNO was in Italy. So I called our educator and she really jumped in and was very helpful. I'm getting ready to get on a plane. She's in Italy. My educator is like, I'm here. I'm ready to go. So make sure you are good friends with everybody in your facility. So when situations like this arise, you've got people that have your back. So anyways, we put the patient into like strict transmission-based isolation, contact containment. So we really emphasized like start cleaning the unit and make sure you're using the correct environmental cleaning, which was the purple top wipes. Make sure everybody's using strict hand hygiene. We needed to double clean the room that the patient had moved from, because yes, of course, the patient had been in another room before we moved them to the room that he was in. So we've got all this stuff going on. Immediate staff education. So you're pulling up stuff on the CDC and trying to get all of this stuff together to cascade out to the staff. And then the last immediate intervention, call the Kentucky Department of Health. So I called KDHP, and when he realized that the patient had not been discharged home, but rather back to an LTAC where he'd been for 6 weeks, they were, how should I say this? Crestfallen. So we all were, yeah. Yeah, so the mess continues. Their recommendations were to do a point prevalence survey every other week until we had 2 consecutive 100% zero conversions. So this was a big ordeal. We sent the first point prevalence in the beginning of June. We did expect quite a few conversions. Before I go on, Rochelle, do you have any questions about how we got here?
No.
Or any other interventions that we've done or anything else that we needed?
Yeah, I want to step back a second. So with talking about what you've already walked through a little bit, give a little bit of context for people who may not be familiar with doing an outbreak investigation and how they even know what an outbreak is. So
Okay.
I pulled really quickly from the APIC text what they consider an outbreak. So an outbreak, very simple, an increase over what is expected in a certain setting or group over a certain time period. Outbreak and epidemic can be used pretty much interchangeably, but outbreak tends to go for like smaller areas. So like within a healthcare facility like yours.
Mm-hmm.
So like for a healthcare facility, an incidence of a case of 1 for Candida auris is going to be considered an outbreak because you should have
Correct.
0.
Correct,
But that
yes.
may not be the case if you have like flu or something like that. You might have 5 people walk in with the flu, but then if that multiplies to 10 and you didn't get any new intakes, then you might have an outbreak because your 5 doubled to 10. So their numbers are going to vary, but in this scenario, you had a N of 1 and that was your outbreak.
And we'd had a lot of education in the IP world about Candida auris, which I'd cascaded down to my team. It just wasn't something that was at that point on a lot of people's minds outside of the IP world. And let me say too, when you first start an outbreak investigation, like I said, I was getting ready to get on a plane. My chief nurse was in Italy. I was trying to deal with the educator and have her cascade out. But if you're not in that kind of panic balls in the air situation, your infection control team should include your IP, your microbiologists, your infectious disease specialists, who I also had to call, pharmacists, nursing, medical staff, managers. So you want to make sure that all your key stakeholders are aware, and leadership, because leadership's going to be involved too. I had to tell my boss, like, okay, we're doing this point prevalence survey. So the next step is to define your case. So you want to look at your lab results, look at your positive cultures. Was it by PCR or was it by culture? Was it, you're talking about the flu, was it a rapid antigen test? Look at your hospital acquired status, were symptoms or positive tests over 48 hours after admission or lack of prior exposure. So you're figuring out what the baseline is that you're dealing with, what your definition is. And then you got to isolate the patient. So we immediately did that.
With your situation, looking here at these key terms. So case definition is that uniformly applied criteria that includes like what specific labs, the time frame, those kind of things that you were referring to. What was your case definition, if you recall?
If I recall. So I know that it was
It's been a while, so.
it has, thank goodness.
Yes.
But it was a culture, which also plays into our problems later, because we didn't have the ability we didn't have PCR ability, but we did have a culture, and the patient, like I said, had been with us for 6 weeks. What other pieces of information? Throw it at me. Tell me what else to
Let's
give.
see. Do they need to have symptoms or no?
He didn't have any, really.
Okay.
I mean, other than
let's see, what else could we have done? Anyone like admitted within that certain time, before or after starts and stops of that 6 weeks?
Well, we didn't
on the
know.
same unit, shared spaces.
So that's stuff that we ended up looking into
later on, which
deeply, yes.
Okay. I do want to, so people can understand the difference between these terms, because you may not totally know. A cluster is just going to be like a group of cases grouped together by time. It's going to be bigger than what you usually expect. Doesn't necessarily mean it's an outbreak, but they're a cluster. Pseudo outbreak has to do with an increase in positive like lab tests, but they're usually from contaminations. And then a line list, which I'm sure you'll kind of walk through, is going to be how you're going to take all the organized chaos and put it on paper or on a spreadsheet so you can help guide through the outbreak investigation.
Yes. So your case timeline, your patient history. So you want to know when all the symptoms and tests became positive. Like I said, he didn't really have any symptoms. He had just gone down to the OR to get debridement, and they sent off a culture. But as far as that timeline and that line list goes, you've got, of course, your patient information, what room they were in, identify any healthcare encounters in addition to the stay that your patient is in currently, any procedures that have happened or exposures about 2 weeks prior. Look at the healthcare staff that's been in there. What services are they getting? PT and OT? Are they getting respiratory therapy? What physicians have been in there? What nursing staff has been assigned to them? What shared equipment could that patient possibly have had with others? Look for, we ended up looking really deep in, like, do our patients have invasive devices? Do they have urinary catheters, ventilators, central lines, any procedures like endoscopy or anything where they've left the unit and gone down and had a chance to share areas? And this line list for me came after the first point prevalence survey. I did not make this line list for the first patient. But also, with that line list, you're looking for a lot of stuff. What I might have said that you didn't catch was that I didn't do this with the first patient. I waited until we got the point prevalence survey back, and we had 5 conversions. But also on the line list, look at your environmental assessment. So look at the cleaning logs for the patient's rooms and the equipment. Look at your hand hygiene practices for certain areas. What's your compliance audit for PPE and hand hygiene? Lots of stuff. So we had that first point prevalence survey, and we had 5 conversions. So that's when we had to really start the line listing and doing a lot of education, because all of our staff needed to be educated. Then we needed to work with the IPs in the host hospital to make sure all that staff was educated, which means we had to work with all the managers of all the locations of all the people that we contract with to make sure. So it's a big deal. It's a really in-depth deal. Before I go on, what else would you like to know?
Let's see. We've confirmed there's an outbreak because we decided you only had to have one. Everyone's on vacation, so the investigation team was a little bit wonky, but got it together. Looked at the different resources. We verified, because it was sent out to the Wisconsin lab. So we verified the diagnosis. We have a
Mhm.
preliminary case
Right.
definition, and then kind of went around with that with the point prevalence. Everyone knows that some of these are going to kind of, depending on the situation, which you've alluded to, are not necessarily going to go in this exact order.
Right.
But because you can't control the way the chips fall sometimes. So leadership's alerted, and this can sometimes go as like the first thing. But then also you don't want to have to backtrack a bunch, a lot of like the crying wolf. So you do want to ensure that something's happening before you let someone know. You don't have to be like 100%, but you definitely want to be like, oh, something's happening. I don't just assume something's happening.
Something's up.
Yeah. You can do a literature review. So look at what's going on, seeing what's in the text. Is there anything going on in the area? Literature review here doesn't have to necessarily stick to like getting on your scholarly articles and everything necessarily here. You're going to look at like what's going on in the area too.
Yes,
That
yeah.
is part of a literature review, not just your studies and research and those kind of things.
Which was unfortunate for Candida auris because there really was not a lot out there at the time. So
we would have liked it to stay that way, but it's not staying that way.
No, it's not. Yeah. Yeah. So part of our literature review was some of the literature or HAN Alert, the Health Alert Network. Is that what it's called?
Yes.
HAN Alert. So they had sent an alert out. So we kind of looked at the criteria for screening patients on that, which I had cascaded out, but we hadn't formalized into a process. So we definitely formalized that.
Those alerts are so helpful
Whenever
they're being sent out. They're
right.
very helpful.
Yeah. And being paid attention to.
Yes.
was part of the problem.
Okay.
So I'm looking at your
you've got your methodology because you've gone through point prevalence. You've started on your line list, and then you talked about that you've been for a procedure. So then you're looking at different patient care activities and different procedures to see who else could be involved. And then I don't think you've talked about environmental sampling. So I think we're kind of at the looking at what's potentially implicated in what all areas we need to make sure we're evaluating and processes and all that good stuff.
So we did not do environmental sampling or healthcare healthcare HCP sampling. And we had a long talk about whether or not healthcare professionals, whether or not our staff should be tested. And we made the decision not to, because when you do that, you have you're opening up another can of worms, and you have to really figure out what you're going to do when you get that staff back. There's no way to treat Candida auris. There's no prophylactic interventions or post-exposure. So, the simple act of doing hand hygiene and wearing PPE should, if your staff has good practices, then you shouldn't need to sample them. Does that make sense?
Mm-hmm. And I've talked with some IPs at a healthcare facility before who the potential outbreak, or the case they were investigating, a rectal swab, and they didn't want to go around and rectal swab a bunch of people.
Right.
Whenever you really don't think there's been an exposure, or like, you got to take all those things into,
yes.
into
yeah. Oh
account.
yeah, absolutely. Yeah.
Yes.
Yeah. No, people don't want to swab their butts.
No.
So also there's no decolonization protocol for Candida auris. So really, what are you going to do? I mean, what are you going to do when you find out you have positive staff members? You're not going to, I mean, what if our whole staff was positive? You can't take them off of work, so then you have to it's a mess. So no healthcare sampling.
Yeah.
And then yes, start initial control measures, which I think I mentioned. We sent out education. We definitely put the patient into contact containment isolation, which means you're wearing strict PPE, you're wearing you're doing strict hand hygiene, bundle your care when you're going into the room, try to have single-use equipment in there. If you can cohort patients, if it gets to that point, do that. If you can use one bladder scanner among them, et cetera, do that. Try to limit the patient's movement through the hospital. We also started screening everybody that came in. So everybody that came in immediately went into isolation and was screened for Candida auris and was not taken out of isolation until that culture came back negative.
I think it's also important to realize with jumping around at the different investigation steps, a lot of these also happen like simultaneously.
Correct.
So
yes.
You're not waiting to complete one to go into the other. You can have 5 things going at the same time. And
I'm not going to start initial control measures after I've
correct.
That's going to happen immediately, especially with something like Candida auris.
While you're confirming, while you're getting your team together,
right.
while you're looking to see what's going on and letting leadership know, you're going ahead and implementing the control measures, So yeah.
Yes. Yeah. So we ended up having to do a whole bunch of point prevalence surveys. And again, they wanted us to get 2 consecutive negative point prevalence surveys in a row, meaning 0 conversions. And we were doing them every 2 weeks. So let's see here. I'm looking, is it okay that I'm following your steps?
I mean,
okay.
This continued point prevalence is where you're looking at that continued surveillance and looking for cases and then adjusting all the things that you're doing as needed.
Right. So regularly review control measures. We had a very tough time containing Candida auris. We are not the only people that have had to go through this. I felt terrible because we were one of the first facilities in the state to really go through this and have a hard time with it. And other facilities have had to go through the pain of it after us. And my heart goes out to them because it is very, very stressful. So I'll just tell you that our point prevalence surveys started in June of 2022, and they did not end until March of the next year. So when you say regularly review your control measures, every single 2 weeks we're going back and we would find a physician who hasn't been on our unit a whole lot, didn't know that we were dealing with Candida auris and didn't put on their PPE in a patient's room. Like having strict eyes on everybody all the time. Other control measures, we ended up renting some UV machines. So we had UV treatment on patient discharges. We also ended up having to shut a floor down to deep clean and control it. So that's part of regularly reviewing control measures and maintaining surveillance, because you've got to make sure that everybody is strictly following your PPE, your hand hygiene, all your containment protocols. And determine if an analytic study should be performed. I don't know about that, Rochelle. I don't know if I can talk about that.
So this is just looking to see if there's a relationship between the different variables to understand why and how things happen.
Gotcha.
So this isn't going to apply in every situation at all. But if we took out this, would this have eliminated this? So really determining if you needed to dive in and do deeper studies to figure out if you could prevent it or how something was related. If all the pieces didn't fall together and you knew everything, then could we dive in deeper and really figure out these relationships and how they're tied together?
So, and that was helpful because, every time we would do a point prevalence survey and have conversions, we would be able to look back because you have your line list. So your line list becomes very helpful. Like, oh, both of these patients, we used the bladder scanner. That we traced one conversion back to a bladder scanner. We traced several conversions back to several different physicians. So we were able to start that analytic study. I just really never heard it put that way, but that was very important. So your line list is going to become very important in that study. So yeah, I'm trying to remember if we did anything else. We ended up utilizing hospital epidemiology, chief medical officer, infectious disease physicians to partner to educate several different physicians. We constantly had to teach and remind and empower our staff to say something if you saw noncompliance. And if they weren't comfortable saying it to somebody, tell me, tell our chief nurse, tell the manager. We'll say something for sure. We will definitely correct. And our epidemiologist was very, very helpful in that, and very eager and willing to do education. So having those partnerships were vital in stopping it.
I think that's really important. And I like that you mentioned that, because in going through the steps of an outbreak investigation, like I just showed on those previous slides, there's nothing in there that's like, make sure people know what to talk about and know when to tell you, and be empowering, which I think goes back to the core of any type of education and interactions with staff that we do in infection prevention. You always want to make the other staff feel empowered to share when something's wrong, or to stop someone in the moment when something's wrong, so that you get the best outcomes and you can prevent further outbreaks or extending the outbreak, and that kind of stuff. And I think that that's something very important to mention and highlight, because it's not necessarily a step. It's not something you can bullet point out in an investigation, but it could be like very key to the success of being able to stop something from continuing on any further, or from any new outbreaks coming in the future. Right.
Yeah. I remember I was cleaning some equipment in the hallway one day, which really isn't my job. So I don't want everybody out there thinking IPs should be cleaning their own equipment, but I was doing it. And some transporters came in to get a patient and didn't put their PPE on at first. And one of our staff members stopped them, and they were like, "Says who?" She pointed at me, she said, "Says that lady." I was like, yeah, that's fine. Yeah. Direct them towards me. But I love that. I mean, they were on it, like they felt, well, they were tired. The staff was tired. And that's something else I remind them too. You're the one that has to do the point prevalence survey. That physician or that transporter or that contracted person, they walked in without their PPE and their hand hygiene, and they took it to somebody else. And you're the one who has to do that point prevalence survey every 2 weeks. You're the one who has to keep putting on for every single patient. We ended up having to put everybody into containment. You're the one that has to put that gown and glove on every single time you go into a patient's room. You are the one that has to, and I hate to say suffer the ramifications, or be punished, but you all are the ones lifting doing the heavy work. You all are the ones that have to come behind those people and do all of this stuff that you all are complaining about for good reason. They're hot. You have to do it between every single patient, even if you just want to go in and give them a cup of ice. It's a pain. So I think that really empowered them too, realizing like, we've got to put up with the consequences of this. I'm not going to keep on doing this because so-and-so didn't do their part. So that was good. And one thing I want to mention too, when it comes to like partnerships and empowering and talking, make sure that you have a good relationship with EVS. If you're a new IP or if you're an old IP, that is something that is going to be hammered into your head, and it should be. Your environmental services department is one of the most critical pieces of infection control. When people, this really bugs me when people say like, oh, from the very top of your organization to the very bottom, like the CEO to the housekeepers are not at the bottom.
Right.
They are not. And that frustrates me. So you better be able to partner up with them, because we ended up doing UV cleaning on discharge, daily environmental cleaning. We ended up having to contract an outside cleaning service, but none of this would have been done without our partnership with EVS. So,
and I mean, you can do all the other things in infection prevention, right? You can test appropriately, you can isolate appropriately, you can stay home when sick, and you can stop this, do all the right things. But if your environment is dirty, it doesn't matter.
Yeah, you're right. You're very right.
It does not matter at all. It's that chain of infection there that environment impacts that entire chain of infection. And you're not going to ever really fully break one of those links if you don't have a clean and safe
Absolutely.
environment.
Yeah, because then your transfer of what's the part in the chain of infection, the transmission, like, yeah, I mean, anybody
Mode
can
of
come
transmission.
by.
Yeah.
Yeah, anybody can come by and touch a surface.
Yeah.
And that person who touched that surface could be the cleanest person in the world. But if they
Yeah.
touch a phone receiver that somebody didn't clean well, then, you know, that their infection control practices are moot unless they are constantly washing their hands. Or, and you know, that reminded me, I wanted to say something. We did not sample the environment, but one thing that you should do when you're working with EVS is have them doing, which they should be doing anyways. You should be getting reports like your ATP reports, your glow gel reports, whatever your contracted services or whatever your EVS is doing to show that their work is effective. Work with them on getting those logs too. So you don't necessarily need to sample the environment, but it might be nice if they are going around and doing a little extra, doing a few extra swabs on a few extra surfaces to see.
Yeah, that's a good idea. For sure.
So
I was
go
say
ahead.
with all this, do you have, okay, two questions here.
Okay.
Have you encountered an outbreak since this one? Not of Candida auris, but of anything in general?
Yes. Yeah. Because there's a high prevalence rate of CRE these days. There's a lot of CRE in the community. So we've gotten those and had to do point prevalence surveys and knocked them out like that. We've had, I think we very rarely have to do a second point prevalence survey. We don't transfer a whole lot of MDROs, but that goes back to your definition, like one CRE, one hospital transmitted straight CRE, when you figure out like, okay, my patient has a KPC and they've been here for 2 weeks. You know, I got to look at that. That's part of your case definition. That's one, that's an N of one, but that's still, you still have to look into that. So we've had those a couple of times, and that's it. Yeah, we've had to do some of those. What was
what would you say is what's one thing that you think would be the most significant thing you learned from your involvement with your C. auris outbreak?
So I'm going to say there are a few things that are very Candida auris specific. So with Candida auris, I mean, you really want to do your screening, that whatever your health department suggests. But we had to, I think education on whatever bug you have that you're trying to prevent. Make sure all your staff understands what that bug is and how it's transmitted and how you clean. Make sure that they know to do their hand hygiene and their PPE. So it's infection control basics.
Like the environment.
Yeah. I mean, it is. You remind them of their basics. It's infection control basics.
Yeah. Well, I don't have any more canned questions here. Do you have any parting words of wisdom you want to leave us with today?
I will say, if you have an outbreak, lean on people. Call your fellow IPs, call somebody. I think that thing took years off my life. I mean, people were so, it was coming off the heels of COVID too. So we dealt with a lot already. And if you did the math, we did about 9 months, I think, from June to March of point prevalence surveys every 2 weeks. I mean, people were just tired. And when I say it took years off my life, it was very, very stressful. Very stressful. So lean on people. You're not alone. You know, you're not alone. That's it.
I think that applies in all aspects of infection prevention. You can't know it all. You can't be everywhere. You can't regulate everything. So use your resources, use your friends, phone a friend. Don't try to don't try to shoulder it all on your own. So,
I mean, on a side note, Rochelle, I think we were in a lot of meetings together, through APIC sessions. And I think you all could see the stress on my face through a lot of it, and sometimes they would be just following a point prevalence survey where we got like 1 conversion, 2 conversions, and it was just so frustrating. And, I was with area hospitals who were all looking at me like, what are you guys doing now for Candida auris? What are you guys doing now for Candida auris? Like,
yeah,
I felt very lonely and isolated. So reach out to people.
Yeah. Well, I mentioned I really just took all the information I shared today from the APIC text, and I do want to just highlight, if anyone wants to contact me, there's my email right there. If you have any ideas for any further Let's Talk About It sessions, something you want to talk about yourself or you want to hear someone else talk about, please shoot me an email. I would love to get that going. And if you need to connect and work on anything infection prevention, please reach out as well. So as we end this, just want to say thanks again, Nikki, for sharing your experience. I always love chatting with you and hearing about all the good work you do and all the things you've been involved in. So thanks for joining me.
Thanks for having me, Rochelle. That was a lot of fun. I hope you'll have me back.
Oh, always. You'll have to push me away.
And if anybody has any questions about what we went through, reach out to Rochelle. She can point you my way.
I'll filter them. Yes. All right.
That's right.
Thanks.
Bye, guys.